this. Hold on, I'll record this. All right. So I do want to introduce my colleague. Uh, Noor is a emergency room physician. He works as an assistant professor at the Department of Emergency Medicine. Well, here's the thing is that he's going up for associate. We had a nice discussion about that process. And the work that Nora has been doing as when he came in as a graduate student, he's impacting an entire country, Pakistan,
Yes.
and doing this amazing work. And this story, and I don't know if he's telling this story today, but the story of his mom and CPR is a amazing story that you will have to hear sometime if you don't hear it today. But this is his continuing story of the amazing things he's doing to change emergency medicine. So, Nora, thank you so much for being with us.
Thank you, Sue. Thank you for the kind introduction. Today, I'm not going to talk about my mom's story, but certainly most of the things are inspired by that story. And so I believe that somewhere down the end, this also is going to connect with my mom's story at some point of time. But thank you very much, everyone, for joining in. And I just wanted to make sure that if every one of you can see my screen and can hear me loud as well. Thank you. Thank you, everyone. So I'm going to talk about something that has something directly to do with learning and saving lives. And I'm just going to talk about that how creativity can help, can not only help people in learn and unlearn, can help in learning new things and unlearning old things, but can also help to save lives. And in the next few slides, I'm just going to talk about the same thing. So the disclosure is that some of the visuals that you're going to see are AI generated. But other than that, I do not have anything to disclose as far as this presentation is concerned. So anywhere in the world, if, God forbid, there is a passenger plane crash, makes a big news. And irrespective of the geographical boundaries or the socioeconomic constraints of a country, any social-cultural background of the country where a plane belongs to, whether it's in Africa or Asia or Far East Asia or Americas, it makes big news. It's all over the print media, electronic media, it's all over the social media networks as well. Most of the times, people across the continents don't even remember the name of the country to which the plane belongs to, but they get the news. And we have got some statistics that every year, only in the United States, approximately 200,000 patients die because of the medical errors, making it the third topmost cause of mortality in the United States only. This is equivalent to 540 passenger planes crashing every year. But you may not hear about it. You may not hear about the statistics or the numbers of people dying because of a medical error that frequently as you do for something like a passenger jet crashing. And why is that so? I'll just give you 30 seconds. I'll let you think. And you can type your thoughts in the chat box. that why do you think that these medical errors don't make the big news? What can be the possible reasons behind this? So I cannot see the chat box. If you can just help me read the messages.
Okay, they're typing right now. They're too common and they only affect one person at a time.
Yeah, yeah. They're too common and they only affect one person at a time. Yeah, that can be one of the reasons.
They're still typing, so you have to give them a minute.
Yeah,
They can be overlooked.
yeah, yeah, yeah.
They're not
And
as
that's
spectacular as a plane crash.
yeah, yeah. All these reasons.
Okay.
Let's see what do we have here. I'm just going to get back to the same point. Um, and I'll connect this question to you later on. But I'm sure that we all have some um, some experiences where we have tried one idea which didn't work. And if you have any of those ideas that you want to share, can you please write in the chat box? Uh, any experience, any idea that you had that didn't work out?
Also, there was one before that, just so you have it. It's always happened. Crashes happen occasionally. So it
Yeah.
always happens. Crashes happen occasionally. That was from the last one.
Yeah.
All right. So now they're sharing an idea that didn't work. Using VR headsets for relaxation for nurses.
Yeah.
In general or about medical errors?
Generally,
Generally.
anything.
Generally.
All right. So
All right. Another one, building a fence that
yeah,
didn't hold the dogs.
yeah, yeah. And you see that in medicine, um, these ideas which do not work are discussed in a conference or a meeting, which we call as the morbidity and mortality meetings. And these meetings happen to discuss medical medical errors that may have caused a significant adverse event to a patient. That may include death as well. And these medical errors are discussed in front of a dozen of doctors, nurses, hospital administrators, and leadership. And they happen very publicly. And most of the time, these medical errors are criticized and have been looked through the lens of criticism and finding gaps and mistakes, uh, rather than seeing this as an opportunity to learn from these medical errors so that they can be prevented the next time being happening. And because of this, most of the physicians and nursing staffs involved in the patient care are reluctant to report these medical errors because uh, they fear that they will be criticized or some punitive action will be taken against them. Hence, the purpose of these morbidity and mortality meetings shift from uh, learning towards um, being criticized and going into a nutshell, and silence prevails, and which are contradictory to the principles that we know about creativity, starting from divergent thinking, avoiding premature closures, or connecting on other ideas. And this is the reason that although these meetings are considered critically important, because they serve as a quality tool for improvement in patient care, but their potential is undermined by the culture of fear and blame. And this results in high levels of anxiety, fear of criticism, and punitive actions um, against the staff involved. And this obviously discourage an open dialogue and search for solutions. And hence, a need was identified to shift this culture of fear and blame towards a culture of learning. And once the great public health specialist, Dr. Lucian Leep, said that the single greatest impediment to error prevention in medical industry is that we punish people for making mistakes. And once you do that, you close an opportunity to grow and to learn from mistakes. And in medical science, if you don't learn from your mistakes, it can lead towards the loss of life. And this is where we thought that how can we improve this culture of morbidity and mortality meetings in healthcare, starting from emergency medicine. And we chose emergency medicine for a couple of reasons. One, I am an emergency physician myself, and I know that the stakes uh, in emergency medicine or in an emergency room are much higher as compared to any other specialty. Emergency medicine sees a lot more critical patients because these physicians and nurses are the first point of contact of any patient coming into an ER, and they face a lot of challenges these days, including overcrowding. We just saw one pandemic. We see disasters, and obviously the change in the geopolitical conditions now are making us see a lot of disaster hit patients as well. So the need for creative thinking in emergency medicine, especially in a room where we discuss medical errors to improve the outcomes of the patients, the need of creativity was even higher as compared to any other specialty. And we made this Stoller's formula of creativity, which is a function of attitude that integrates knowledge, imagination, and evaluation, um, to what we propose as an intervention to improve the culture of morbidity and mortality meetings in an emergency room where I work. And the methodology that we chose, or an intervention that we chose, was was a combination of appreciative inquiry and creative problem solving. And we chose that because we believe that it's going to create a fine balance um, between appreciative inquiry and creative problem solving, as one focuses on the positive change, whereas the CPS focus on the creative problem solving. Uh, Both are collaborative processes and both are structured processes as well. And both shift the focus from finding negativity and blame towards a more structured approach towards finding solutions and implementing them with the psychological safety that requires that is needed, especially in these rooms. So the traditional morbidity and mortality meetings, um, they are focused on finding gaps, and then they think about filling those gaps. And when you and as I just described in the beginning, that because of this unidirectional process, physicians and staff would discuss these medical errors, feel insecure because of the fear of criticism or facing punitive actions. Hence, they never actually uh, achieve those solutions which are required to help solve these medical errors and prevent these medical errors in future. Whereas the appreciative inquiry focuses on discovering the positives and discovering good clinical experiences and preventing errors in the future as well. There's a dynamic balance between the core of the creative appreciative inquiry process. We know that uh, when we move from the area of familiarity to the area of discovery, new insights emerge, and those new insights can translate into actionable solutions, um, and not only actionable solutions, but also novel solutions that can actually help um, uh, improve the outcomes, that is, reducing medical errors in this case. And the 5D process of the appreciative inquiry, that was the intervention that we proposed. Um, the 5D, including defining the challenge, discovering what gives life, dreaming what might be, designing the solution and delivering it. Whereas every step was supported by the creative problem solving um, process, including divergent and convergent thinking, including different tools at every step. Um, Similarly, um, combining the appreciative inquiry with creative problem solving at every step would help us not only to see the problem or the challenge with the lens of appreciative inquiry, but also push the participants to think beyond the obvious, um, and and to think creatively about the potential ideas at every stage of appreciative inquiry. And finishing it from loop to loop. That is, from the first step of defining what's the challenge, to coming up with a solution, and to come up with sustainable action plan towards that solution. So the objective of our study was to understand barriers to participation in the traditional morbidity mortality meetings, which are the medical error review meetings, and to assess the feasibility of integrating appreciative inquiry and creative problem solving into these meetings to foster a positive, collaborative, and non-punitive learning environment. We chose a pre and post survey methodology, where in the first phase, we disseminated a survey um, which determined the perceptions of the emergency medicine nurses and staff who participates in these mortality and morbidity meeting. Uh, all of these nurses and doctors belonged to one of the largest tertiary care hospitals in Karachi, Pakistan, and they were all uh, trained ER nurses and doctors, including the residents, interns, and of course the faculty members as well. And then they went through a one-day workshop where they learned how to integrate appreciative inquiry and creative problem solving in the traditional morbidity and mortality meeting. And then we conducted a survey again to determine the feasibility of this methodology, which is appreciative inquiry and creative problem solving, in their traditional morbidity and mortality meetings. So the pre-intervention survey identified top 3 barriers to participation in these meetings um, between the emergency room doctors and nurses. 74% of the participants believed that the fear of criticism was a major barrier for their participation, followed by anxiety and fear of punitive action. And then we had this intervention where we had a workshop about appreciative inquiry and creative problem solving, and the participants had a hands-on practice of this process while integrating this into their traditional morbidity and mortality meeting. And this is actually one of the real cases that the participants came in the workshop with. So they brought a case where an elderly female who was brought in the emergency room with vomiting and had some blood in that vomiting. Obviously, she lost a lot of blood, so she was transfused blood in the emergency room, and the gastroenterologist was taken on board, um, who actually advised an inpatient admission for the patient and plan an endoscopy while the patient is admitted, not in ER. But after 4 hours, the patient had vomited again with a lot of blood in it, and then the patient recreated. And then she was rushed towards the CT scan to get a CT scan of the abdomen to identify where she was bleeding from. The bleeding artery was identified, but unfortunately, it was too late for her, and she expired in ER while waiting for the curative intervention. So this is the case that the participants actually brought themselves in the workshop, and see how does AI, that is appreciative inquiry and creative problem solving, will work. This is just an example that during the first phase of defining the challenge, these were the top three challenges that the group identified. What might be all the ways to prevent morbidity and mortality related to upper GI bleed? That is, in the same case, if a patient comes to an ER with blood and vomiting. How might we improve communication and coordination between different departments to improve the outcomes of such patients? And what might be all the way to keep track of timelines for interventions, for life-saving interventions in these patients? So this is just an example of the first phase of the appreciative inquiry. But in traditional morbidity and mortality meetings, like I said, the focus is on finding the gaps right from the very beginning, right from the very start. But through this process, the participants were guided to or facilitated towards converting that problem into a challenge statement, and that shifted their mindset. And trust me, in the traditional morbidity and mortality meetings, there's a lot of personal statements going across, and the focus is completely out from identifying solutions and focusing on gaps, and this creates a blame and shame culture. And of course, after that, the participants went through the cycle. They defined the challenge. Then obviously they brainstormed about the possibility, but they also went through the good experiences, that what went well in this case, how can they build the positive experiences and improve what went wrong in this case, and then obviously the design and intervention and the design and action plan as well. Because this was a feasibility study and the participants were about 15 to 20 participants, we are still developing that intervention or solution that came through this process. But the result of this feasibility trial were quite encouraging. So As far as the impact of the appreciative inquiry on meeting dynamics was concerned, there was not only the statistically significant uh, uh, positive learning curve in this study, but also the qualitative feedback showed that the participants were actually into the whole process throughout these morbidity and mortality meetings. They perceived morbidity and mortality meeting less punitive and more solution oriented as well. They were also uh, much more comfortable in collaborating and communicating their own feelings going through that case, and that created a psychological safety net across throughout the meeting as well. Because these physicians and nurses actually go through a lot of psychological stress as well when they see these patients, um, and when they know that something that didn't went right actually resulted uh, in a bad outcome and as bad as death of somebody who can be saved. So the impact of the psychological toll on these physicians and nurses is immense. But after this workshop, they felt a lot more comfortable sharing their own thoughts and ideas and solutions as compared to the traditional MLMs. Um, Change in meeting dynamics post-intervention. So nearly more than 90% of the participants believed or felt uh, that the meeting dynamics of these meetings significantly improved as compared to the traditional morbidity and mortality culture as well. Um, and then the feasibility. For 47% of the participants were comfortable using appreciative inquiry and CPS um, during these morbidity and mortality meetings. Although it seems that 47% is less than 50%, less than half, and only less than half of the participants were comfortable using that. But considering that none of these participants were exposed either to appreciative inquiry or creative problem solving before, and appreciative inquiry is not a very straightforward process to learn on a first go. We still believe that 47% out of these 100 participants were quite an encouraging number. Whereas more than 90% were willing to continue the same methodology in the traditional morbidity and mortality meetings, and nearly 90% of the participants thought that this methodology is effective for collaboration, not only intra-departmental but also interdepartmental collaboration for morbidity and mortality meetings as well. So, in conclusion, what we found that appreciative inquiry and creative problem solving uh, was feasible in morbidity and mortality meetings in the emergency department of a tertiary care hospital in Karachi, Pakistan, because it positively shifts the culture of the meetings. It reduces fear and anxiety and promotes constructive dialogue. But more than anything, it improves psychological safety and engagement, which is essential and a cornerstone for these meetings and to come up with solutions uh, to these complex problems and complex cases, help save lives. So this is my last slide. That some of the lessons, some of the best lessons we ever learned, we learn from our mistakes and failures. But the error of the past is the wisdom of the future by Tyron Edwards. Um, but it's always easier said than done, right? If the question should come to mind that if learning from mistakes was that simple, then why would 200,000 people die from medical errors every year only in the US? And if we don't have answers to that, this means that this certainly is a complex problem to solve, requiring better solutions. And whether creativity or creative thinking or creative processes or creative methodology would help solve these complex problems like reducing medical errors, can help can really can creativity really help solve these complex problems is the answer that we are still seeking. But especially in this part of the world, that is Karachi, Pakistan. But the initial results of this feasibility trial are quite encouraging, and we hope that we can be able to scale this up in our next studies, which are more interventional and will cater a larger cohort across different hospitals in different regions in Pakistan. And we just hope that that we'll be able to find a link that creative thinking and creative processes can not only help improve learning, but also help save lives. Special acknowledgement to Dr. John Cabra, who helped me provide relevant literature for appreciative inquiry when I started this project last year. Uh, uh, he was of immense help of helping me to do the literature review and to brainstorm ideas about how to integrate this process uh, in the medical world, especially in emergency medicine. Stop over here. I'll stop over here. Thank you very much, everyone, for your time. And back to Sue.
All right, thank you. Wow, that is a huge shift from, the blame game kind of a situation to having the opportunity to do it in a safe environment. So one of the questions is, how did you set that up for them? How did they and we have a couple in the chat as well. How did you explain the change in process prior to taking them to that session? What was some of the language you used or the ways that you helped them get ready for that?
Yeah. Um, so because I also go through the same process and have been going through the same process for many years now. So I know about the water cooler chats that happen before and after these sessions. Um, and I'm fully aware of the anxiety and the fear of criticism and punitive action. It's just like um, putting somebody in front of everyone for cross questioning, like in a courtroom, and that's exactly the feeling that any nurse or physician who actually presents these medical errors feel and go through. So I knew the need, um, but to convince them about a different methodology being integrated into medicine, it took me some while. So initially, I wrote a letter to the chair of the department suggesting that, look, I want to change the process in emergency medicine in a manner that they conduct their morbidity and mortality meetings by integrating some of the creative processes. So first, I have to convince the hierarchy, it's the leadership, before I actually go to the real stakeholders. So I have to convince him. And because I'm in an academic institution, I need to give him evidence, scientific evidence um, about creativity and creative thinking. And it took me about 3 months to convince him to integrate a methodology which they are not used to, which they have never used, and using. I don't know what is your experience, but in the medical university where I work, uh, they feel that creativity is a buzzword, and it takes a lot of time and effort for people to get convinced, especially in medicine, to get convinced that creativity is science. Basically, it's not hypothesis only. It's also an applied science. So I have to convince my chair, and then I have to run the whole process to him a couple of times, and then he actually got convinced that all right, you need to go ahead and talk to the team. And then I conducted a couple of orientation sessions with the group about what is appreciative inquiry, why is it relevant to emergency medicine, how am I going to integrate this? It's not going to go there. We are not going to implement it, impose this process on them. We're just going to adapt a phased approach and so on. So the phase one will be the feasibility trial, phase two will be on the larger scale, and then so that's what I did. So rather than to impose on them a completely new process, I tried to adapt a phase-wise approach while taking the leadership in loop as well, and that worked.
Mhm. Okay. Yes. Yes. Makes a lot of sense. Now, can you see the chat or you want me to read? Um,
Yes, now I can see the chat. Yeah,
okay. All right. So the first one starts with given the risk.
yeah. So, given the risk or errors in medicine is death and increasing litigious nature of patients, how did this translate into the actual quantity of errors versus previous periods, and how was it received by the medical legal and risk department? Yeah. So the medical legal uh, they're very focused. The medical legal department in my institution, they're very focused. They rather than so for us, and especially for me, during phase one, the outcome is the process. But for the medical legal department, the outcome is the product, and that's whether this process is going to actually reduce the number of medical errors in my hospital as compared to the traditional morbidity and mortality meetings. And and this is like phase two. So the phase one was like assessing the feasibility of this new methodology, and phase two will be whether this methodology actually works as compared to the traditional methodology, whether the nurses and physicians are going to change their behavior and are going to um, change their actions that leads to the reduction in medical errors. And that's probably the phase two trial where probably we are going to where we'll seek a grant as well, an intramural grant for this, and let's see if that works. But you're absolutely right. The stakes in emergency medicine are high. It's a matter of life and death. But um, having this methodology to analyze and find the right gaps to look for the right solutions that can help reduce medical errors probably is a bigger outcome. That probably we're going to see in the next phase. I hope I answered your question here. You helped me realize that healthcare has to be fixed from inside, and outside feeds the fear, blame, and anxiety. Do you see this correct? Absolutely, absolutely. Um, um, I think self-awareness and self-realization and getting oneself out of their own way first is probably the thing. Um, Most of the time, I, an emergency physician, will try to justify my actions rather than to think metacognitively and to assess the situation holistically. And um, when my case has been put in front of public, um, I don't like it because I'm being judged. Uh, but I completely agree that it has to come from inside. We just probably need to find um, probably need to find the right process for that. Currently, the processes that are in place in my hospital are like accreditation from different bodies, from different regulatory authorities. But the real staff or people who actually make the difference, the doctors, physicians, the admin staff, and so on, who probably are going to be the real change makers, they feel these regulations that they're as like just like they're dictated, and they don't like to be dictated. They follow the rules, they follow the regulations, which are important as well, but they see it from a completely different lens. And I think creative thinking and creative problem solving and these processes may help to um, clarify um, these challenges more while they see it from a different lens. US performance improvement departments currently are elevated to senior levels of leadership. Um, they use a different tool set process like Six Sigma, Lean, Have, or Shadowed. Um, Lean, Have, Overshadowed CPI. Do you see this? Yeah. Yes. Um, 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 I would also like to hear your experience, Anthony. But here, where I work, people are not actually aware of CPS. They don't know what CPS is. Lean Sigma um, is a quality lingo, right? Um, because I'm an emergency physician and I just try to explain to you through an example. Um, I apart from being an emergency physician, I also educate the community in CPR and bleeding control, this is where the story comes in from my mother, because my mother passed away because of a cardiac arrest. So I started to educate people in Pakistan in CPR and bleeding control. 5 years back, we started this program called as the Pakistan Lifesavers Program. Now it's almost 6 years, and we have trained more than 500,000 Pakistani citizens in these skills till date. More than 50 million um, um, students are now being exposed to these life-saving skills in their school through their school curriculums now as well. But when we started it, uh, we 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 felt extreme resistance, and wherever we went in schools or colleges, um, there was we found um, dominant presence of international lingos or bodies in Pakistani schools. So in one school, when I asked the students that what is the emergency number that you call in case of an emergency in Pakistan, there's a separate number, by the way, emergency response number in Pakistan. But just can you guess what number did they mention? They mentioned 911, and we felt that it's like we need to break that monopoly. CPS, I feel, Anthony, is probably the same thing here. We need to probably have some more evidence, need to educate people more about CPS, and then compare CPS with quality processes like Six Sigma. I think Anthony's got his hand raised.
Norb, it's been 7 years and you really made me feel you've got a good handle on this. I lost my wife 7 years ago at Cleveland Clinic to a bilateral lung transplant that went awry. And the pride, the fear, the blaming, I mean, it was all evident. And it all came out. I sat with the associate director of the lung transplant program, the same guy, 8 months of evaluation on my wife, 5.5 months on a donor's list, 4.5 months out of surgery, and they couldn't get her off the ventilator. And she was lethargic. He sat at the bottom of the bed. Now, same physician. And I looked at him straight in the face and I said, Doc, the system let you docs down. He looked at me and he opened his heart to me. He just literally opened his heart. And there was just fear. It was just like he could never even say he knew things were going awry, but he was so afraid to say anything. And his patient load was phenomenal. Now you can imagine they do 100 lung transplants a year, and you can imagine it's like, where does he put his time? Does he fight for me or does he fight for that patient in the other bed? I saw all this. I saw myself in the middle of a problem and I couldn't fix it at all. In knowing CPS, understanding team development, I really seen where all the problems were. Well, I couldn't do a single thing about it, Norm. And you just brought it out to me because I've been on a journey to try to fix it. But you just brought it out to me. Outsider can't do this because of that fear, that blaming. And this was I mean, it ended up, what happened was, is they did away with an lung transplant ICU 5 years ago due to cauterization. They squeezed it in with the heart transplant ICUs. And all the therapies in recovery are totally different between the physiology of the heart and the lungs. And you could push the heart, but you can't push the lungs. And what they were doing was they'd walk away from her for 3, 4 hours, come back, and she was completely lethargic. They did that for 4.5 months, and I couldn't get it across to them because they didn't want to hear it. So Norb, I don't want to go too deeply into it, but you really made me help me realize an outsider skilled with this stuff isn't going to fix healthcare in the United States. There's no way. In CPS and appreciative inquiry, I mean, it was par. You did exactly what is going to fix healthcare. Thank you. I appreciate where you're going with this.
Well, first of all, Anthony, I'm very sorry to hear your journey. And may your wife rest in peace. Um, but these are the journeys uh, that we see almost every day. And there was a bunch of medical students who actually rotate with me during every shift. And once when I started my certificate course in creativity and change leadership, I started to learn about the CPS and divergent and convergent thinking. And um, because I thought that research is a very tedious process, it takes a lot of approvals and so on, I just started to collect some anecdotal evidence. And during one of my shifts, uh, I asked them. I started from the traditional learning that happens in the medical university these days, and I'm sure that's exactly the same case in the US as well. I I started with the convergent thinking, not the divergent thinking, the critical thinking, and I just gave them an example and I asked them what can be the possibility. This is the patient. These are the symptoms. Um, what can the patient have? What can be the possibilities? They came up with an idea, and I criticized that idea. Right? Why did you say that? Why didn't you say the first one? And the thinking were like gone. They couldn't speak up. It was pretty normal to me because that's what happens. But on the next day, I applied the divergent thinking towards them. And I asked them to come up with a number of differential diagnoses without the fear of being judged. And they were just final year medical students. They were not even interns. Um, and they came up with a long list. Um, and and some of the diagnoses in that list were actually mind blowing for a final year medical student. So we are trained as doctors. We are trained to think critically because we believe that the stakes are high, which is right. But jumping to convergent thinking first can actually cost lives, and then we defend these decisions. We don't want to accept or admit it, and we don't actually. We are afraid to admit and accept these mistakes for very obvious reasons. But exactly that's what's happening in the healthcare as well.
Right on, Norb. Right on. I would be behind you, but I'm an outsider. And if an outsider could ever support you someday, please call on me.
Uh, Well,
Thank
on that note, I will say very profound. Nor, I have to say, what you just finished with was so enlightening that you are trained as doctors to look critically, and what needs to be brought forward is that divergent thinking. And so thank you for that, and thank you for all that you do. This is very exciting to look at the psychological safety in such a high risk situation, and to be able to change that thinking so that better outcomes happen. So not easy, and we thank you for being a champion. And thank you for presenting at sea today. So, for all of you, thank you for coming today and yesterday. And all of the presentations will be up on our YouTube channel. And we hope that you will continue your connections with us. So, thank you, everybody.
you. Bye bye.